All right, so good evening, everyone. Thank you so much for tuning in for today's lecture, which is part of the Women in Surgery Interest Group lecture series. Today, we have the honor of receiving Dr. Doughan as a guest lecturer. Dr. Samir Doughan is a clinical assistant professor of surgery at the American University of Beirut. He had completed his medical studies at AUB before becoming a resident in the Division of General Surgery at AUB also. He then completed his fellowship in gastrointestinal surgery at Watford and Mount Vernon Hospital, and then at East Sussex Hospitals, both in the UK. Some of his main clinical interests are inflammatory bowel disease, pelvic floor dysfunction, colorectal cancer, and laparoscopic surgery. Today, Dr. Doughan will be talking to us about perianal disease, which is a topic that will be rather different from our previous lectures from our series, and one of our more specific topics, which will sure be interesting. During this lecture, we would like to kindly ask you to please mute your microphones throughout, and we will be taking lectures all throughout the chat box, so feel free to type in any inquiries that you might have. So I will now be giving the floor to Dr. Samir Doughan, if he would like to start.
Well, hello everyone. Thank you very much for inviting me to this very interesting series in order to sort of expand your clinical knowledge about anorectal diseases. I will try to divide it the way I understand perianal disease. I urge you all that this is an interactive session, so you're all above the level of being dictated by a PowerPoint. It's a discussion on issues you should know and you should understand. So if there is any point in time where you want me to stop, please you either send me a chat or you just can interrupt me and I can stop and answer. So let's start the discussion as always is how do you see or go through a consultation for a patient coming through your clinic with a perianal complaint. The three issues you need to always ask are, am I dealing with pain? Am I dealing with a lump? Or am I dealing with bleeding or discharge? And these are the three main topics. And if you all memorize it this way, more or less you encompass most of perianal diseases. And then each one of them, I'll divide it into the main category of the way you think about it. So the first thing that will come to my mind is I have a patient who comes into my clinic and who says, "Hey doc, I have been struggling with anal pain for a long period of time." And this is when I have to dig in with the following questions. So is this pain permanent? Is this pain worsening? Or is this pain associated with a lump? Or is this pain only upon defecation? So the real issues are, why am I asking these questions? Because if I know the answers to all these questions, I will most likely decipher what this patient has before I even examine the patient. Now, it's very important, and I keep on reiterating during the session about the importance of history taking, because there are issues that you really need to ask in order to understand what you're dealing with. So let's start with the first complaint is that I have a patient who has pain upon defecation. So when a patient comes in with pain upon defecation, is describe for me that pain. And most of the patient who will give you the answer of, well, it's like a razor blade pain going through my anal area, or is it like a glass going through the area, then most of you should have the heralding sign and symptom of I am dealing with fissure. So, and to be extremely honest, most of the problems we face as colorectal surgeon is that pain in most of the teaching, and which is wrong, is that pain means hemorrhoidal disease. Pain does not mean hemorrhoidal disease. So if I ask you or urge you to take that with you as a lesson, then you should understand that pain is not related to hemorrhoidal disease. Pain is related to mostly an anal fissure. And this is then where I have to ask the questions that, am I dealing with a simple fissure? Am I dealing with a fissure that is related to inflammatory bowel disease? Am I dealing with a traumatic fissure? So these are when you have to ask the questions about, have you had inflammatory bowel disease? Is there any history of trauma? All these sort of issues. And in all these questions, you have to be specific and you have to be courageous enough to ask the questions of whether or not most of the fissures are usually the regular fissures that you see that are not related to inflammatory bowel disease, that are not traumatic. So they are related to what we know very well, to a hyperspastic internal anal sphincter. So that's essentially where you have to think about it. But always remember, you will always get caught into the fissure that is the heralding sign of Crohn's disease, or a fissure that there is a suggestion of a trauma behind it. So keep this in mind. So now then, what do I do with a patient who has a fissure that I need to examine? Because the examination of someone who has a very spastic internal anal sphincter and a fissure is very painful. And this is where you have to reassure the patient after you position them in the right side up position, knees up, and trying to reassure them constantly and permanently that you're not going to cause them pain. Because you have to believe me that a lot of these patients have been through heralding cruel form of examinations by colleagues of yours, where people have come to examine them and they have a very spastic anus, and then the digital rectal examination or the digital anorectal examination is not comfortable. So you have to reassure them that this is not going to be comfortable. And when you examine them and you inspect the anal area and ask them to sort of push out or try to start to conceive starting the idea of defecation, you can see all the signs of a fissure. You can see the sentinel tag and you can see the cracks in the mucosa. So and then we'll decide how we're going to treat the fissure. So it's very important in these circumstances as to how to examine the patient. Now, when we do an anorectal examination for fissure or for anything else, you have to always be very careful and look for any specific details of other associated anomalies. Now, a lot of people, including and you will see that in your career, a lot of people say, oh, but there are hemorrhoids and this is a very congested area. Well, of course it will be congested area, because with the fissures and with a chronic fissure, you will have very engorged hemorrhoids that will be problematic. So, but you concentrate, as a physician, you concentrate on the fissure. The patient is not coming to you to clinic because of the hemorrhoidal symptoms. They're coming to you because of the anal pain, and the anal pain is related to the fissure. So in order to consider what do I do with fissure patients, well, then you have to consider what do I have in front of me. Do I have a lady? Do I have a young girl in her 15, 16, or do I have a man, or do I have an older person? But at the end of the day, most of the treatment is the same. So most of us will consider what we describe as a chemical sphincterotomy as a treatment, which is you give them some form of ointment, and we all know that these ointments are derived from cardiac medications. They are either ACE inhibitors or they are nitrites, and that they work on the internal anal sphincter to reduce the spasticity. You reduce the spasticity, hence you get to improve the fissure. And this is usually the start of all of us to try to treat these patients. And if we look at the literature, giving them nitrites or the current available medication is called rectogesic. The success rate is between 60 and 70%, which is quite a good rate for someone who wants to avoid an operation. And if you want to check on diltiazem or nifedipine, the success rate is reported around the same thing, around 70%. But you have to highlight to the patient that this is a long treatment, and you will need at least 2 months of treatment, and you have to extend it to 4 months. It's not a short-term treatment; it's a long-term commitment from the patient, so that they can get to the level of decreased spasticity of the internal anal sphincters before the fissure heals. And then, if this does not improve, so if you give them all a trial, and if this does not improve, then you move on what I described to the ladder of the fissure treatment, and that is, do I do a sphincterotomy, a proper surgical sphincterotomy, or do I consider another form of chemical sphincterotomy by Botox? Now, you can give either Botox in the clinic, which I wouldn't advise because it's painful, patients are very anxious, and you need to do a proper assessment of the fissure and inject the Botox properly, either in the fissure or in the intersphincteric space. But that's a possibility. And the way I look at it is, I usually offer most of the ladies Botox treatment because of the importance of the internal anal sphincter in the passive form of continence, and I will usually offer most men a surgical sphincterotomy unless the patient completely uh, objects to the idea of surgical sphincterotomy. So that mainly covers the part of fissures. So now, what do I have if I have a patient who comes to my clinic and he says to me, I have persistent pain that is worsening, and I feel a lump that is enlarging and getting more and more painful. And this is where it's very important to examine the area very well, because now I have in my mind the possibility of an anal abscess. And all of you would know that the idea of an abscess, that you see a fluctuating red, tender, hot area around the anus. But keep in mind always the caveat that you may not always have the perianal abscess that you can see. You can have and see that you might have an ischiorectal abscess, so a deeper form of abscess, and that only you will find out the presence of the abscess if you do a proper examination and feel the bulge or the fullness from inside the anus. So this is the possibility of an abscess. And then what do I do with an abscess? Well, it's very simple. It has to be an incision and drainage. Sometimes you can try different areas, but we try in special circumstances. But the approved treatment for any questions in your exams on the board, the fellowship exams, most of them, if you have uh, a perianal abscess or an ischiorectal abscess, the answer to that is a drainage. And the drainage can either be done in the form of an external drainage or a peranal or a transanal drainage. So you do your drainage to the inside of the anus or through the skin to the outside, depending on how, if you feel a bulge and you can drain it, yes or no. So this is what we have to think about. Now, what about the then with perianal abscess? Before I close the issue of an abscess, because we're going to jump to that matter at a late stage of that discussion, is what do I do with an abscess after I drain it and the patient come to clinic? And what do I say to the patient? Well, it's very simple. You say to the patient, you have a 50% chance that you will get a fistula, and then we will treat it accordingly. But not all patients where you drain their abscess will have a fistula. The third issue of pain is when you have someone who has a bulging lump that is painful for a few days, and then it stops being painful, and this is usually an external thrombosed hemorrhoid. So you examine the patient again in the same position, you look at it, and you see a tear, a lump of violaceous coloration that is around the distribution usually of the hemorrhoids. This lump is usually an external thrombosed hemorrhoid. Most of the time when they come to your clinic and you assess it and you examine it, you feel a hard lump that is not painful. And it's not that painful and it's not tender. So you examine it, you assess it, and usually if it's not painful, it doesn't need anything. Most of the external thrombosed hemorrhoid will not need anything. You just give the patient some painkillers. You can give them a bit of ice packs to sort of numb the area and reduce the size of the hemorrhoid, but they don't really need any surgical intervention because they eventually resolve. And you will see from most of my discussion is that I usually err on the safe side or on the very conservative side of the treatment, because I prefer not to manipulate a lot the anal area, because all these operations have complications, and this is what you have to keep in mind. So let's go back to the issue of hemorrhoids, and please keep in mind as future surgeons that the anus is a very small, tiny area, and it doesn't really need that. It cannot take multiple operations. So you have to be very careful when you choose the operation, the kind of operation, and what you should do. So that covers most of the patient who comes to my clinic with pain. So I reiterate, is it pain related to defecation, and is this a fissure? Is this a pain that is related to a relentless form of pain that is worsening with the appearance of a lump that is increasing in size and becoming hot and tender? And that's the scenario of a perianal abscess. Or am I dealing with a lump, a blue lump that comes out that is painful for a few days and then becomes non-painful, and then I'm dealing with an external thrombosed hemorrhoid that in most of the times can be dealt conservatively with some ice packs and some painkillers. Rarely you need to consider either excision or drainage because they eventually resolve. So what do I do now if a patient comes into my clinic with the idea of a perianal lump, a lump that appears upon defecation, that prolapses, sometimes reduces on its own or not, most of the time associated with bleeding, and this is where you start to have to think about, am I dealing with hemorrhoidal disease? And taking into account what I have mentioned earlier is that hemorrhoidal disease is not painful unless the hemorrhoid prolapses to the outside, and or the whole rectum prolapses to the out, or the whole hemorrhoidal plexuses prolapse to the outside, then they become painful. But the regular pain that patient comes to me in clinic, this is not hemorrhoidal pain. They usually are hemorrhoidal lumps coming out in and out of the anal area, reducing after going to the toilet. Most of them are associated with bleeding. And then it is very important to ask the following question to the patient. Are you a chronic constipator? Do you struggle with constipation? What is your diet like? In the current days and age, most of the people who walk to the clinic are busy people with their work. They don't eat very well. They don't eat at home. They eat at work. Most of the food is junk food related. So they do not have enough fruit and fiber, and they don't drink a lot of water. Some of them smoke. They go out after work, and they binge on alcohol. So they have all the necessary requirements to become chronic constipators. So it's very important to ask them. That's the case. Then you have to start talking about, how do you modify the diet modification, the introduction of more fiber and more water into their diet. The second question you need to ask is, do you strain when you sit down and you want to go to the toilet? Because this is very important, because the more straining you get, the more the tendency you have to prolapse these hemorrhoids, or to push the hemorrhoids, or to fill the hemorrhoids with more blood and cause them more congestion, hence the worsening prolapse of these tissues. And the third question you need to ask, do you sit longer on the current toilet seat? And you all would know that the current toilet seat is very comfortable. A lot of people can sit hours and hours and hours on the toilet seat, reading newspapers, or currently reading, checking their Facebook, doing their emails, replying to a lot of the regular daily questions through that morning or night habits, and this creates the tendency for the hemorrhoidal tissues to prolapse. So these are the three important questions you need to ask. And once you ask them, then you have to make sure that the patient understands that they need to be rectified. And if you go through the patient, and if you go through literally diligently with the patient around, modifying their dietary habits, modifying their toilet habits, preventing them from sitting there for a long period of time, I can assure you, you have treated between 50 and 60% of your patients that walk in with hemorrhoidal disease. And you can easily convert, people with lumps and bleeds to people who are completely symptom-free, because you have stopped them from essentially increasing the congestion in the hemorrhoids, and hence coming to you with symptoms. Now, what do I do with the patient who, despite all the sort of conservative treatment that you have tried, with all the modification that you have tried, and the patient doesn't improve? Well, then you can use a bit of medications, and the use of venotonics, or to reduce the pressure in the venous system, is advocated. And you give them some ointments and some suppositories in order to try to reduce the hemorrhoids in size. It does work, but we don't really have enough quantification in the literature of how much of this works. I think there is enough quantification that if they alter most of their habits, they will have around, you get a success rate between 40 and 50%. Now, what do I do with the patient who does not improve? And what do I have as options in terms of treatment? Because most of these patients, after you've tried them for everything, they will come to you in clinic and say, well, doc, I'm not better. What do I do? Well, then you have to think, can I treat them in clinic, or do I have to take them to the operating room? And if you can treat them in clinic, then the two available options are either sclerotherapy, which I really wouldn't advocate it at this stage. If you haven't done enough sclerotherapy, and to perform sclerotherapy, you can use either oily phenol or hypertonic saline. But I would not advocate it if you haven't done enough, because mainly injecting into the interior, especially the anterior hemorrhoid, because if you inject into the anterior hemorrhoid and your injection of sclerotherapy gets into the wrong areas, then you have a lot of complaints from the patient. In ladies, it's usually dyspareunia. In men, it's usually hemospermia. And these are very sensitive issues, and then the patient. So the one that I would advocate is to consider banding. And banding is very successful if done in the right hand. It's a painless procedure. You can do it in the clinic, especially if you have the setup and the suction machine. The success rate in good hands is around 70 to 80%. It's painless procedure. You can repeat it. You can do it again. It doesn't cost much. And a lot of the times when you, as a lot of my mentors used to say, band, 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 and then consider surgery. After 3 sessions of banding, a lot of people will not come again to a clinic and say, I'm fine. I've done it the first year. I've got a reduction in my symptoms of 50%. The second time I've done it, I'm more or less symptom free, and the third time I'm really completely with no symptoms and I'm fine. So banding works, and it works very well if you're expert at it. It's a very simple procedure. It should be painless. You can do it in the clinic with minimal cost. Now, if this doesn't work, then you have to consider surgery. And now, when you have to consider surgery, you have to think about two issues. What am I dealing with in terms of surgery? Am I dealing with a simple large prolapsed hemorrhoid that is to the outside and that is causing bleeding and hygiene symptoms, or am I dealing with circumferential sizable hemorrhoids that are constantly bleeding? Um, and am I dealing then with a hemorrhoid that has has the continuous component of a large internal hemorrhoid and a bit of a florid external component? Well, you have to think about it this way. Each patient will have his treatment tailored to him in a different way. So no two hemorrhoids are treated the same way. But the options available are the old standard excisional hemorrhoid, and which is a treatment I would offer for someone who has a single pedicle that is prolapsed and that I cannot really um, more or less reduce to the inside. So these usually you can give them a simple excisional hemorrhoidectomy using a certain energy source or using simple diathermy. Uh, but you have to be very careful about how much skin would you cut and how much mucosal gap would you leave, because of two issues. Because of, first, the skin, it is related to pain, and for the mucosal gap, it's related to stenosis. Um, and you should be able to get most of the patient very quickly satisfied with the outcome for what I describe as a single pedicle excisional hemorrhoidectomies. The circumferential disease are more challenging, and then you have to think about other forms of less painful procedure. So the current available procedures are either we give them a hemorrhoidal artery ligation, so where I ligate the hemorrhoidal artery under ultrasound guidance, and then I would suture the prolapse segment and pull it up, performing what we describe as a rectoanal rectopexy, or described in a different way, the mucopexy. Essentially, you're trying to push that hemorrhoidal element backward. Now, the current available method that we don't really have a lot about, but we're expecting decent results from the literature, is the laser procedure. So what we describe as a hemorrhoidal laser procedure, where I go with laser inside the hemorrhoidal cushions and try to perform a laser sclerotherapy, if you want to think about it, and then hence reduce the size of these cushions. We don't have a lot of result, but we have seen, and we're expecting to hear good results. We have to wait. We have to wait for the final results. Hemorrhoidal arterial ligation has been in the market since early 2000, so we have enough results. Hemorrhoidal laser procedures has been there only for the last few years, so we don't have enough long-term results. Now, there is another procedure that is available in the market, which I would not advocate, and it's called procedure for prolapse and hemorrhoids, or PPH. And this is what we describe as stapled hemorrhoidectomy. And this is a circumferential hemorrhoidectomy or circumferential excision of a rectal mucosa with all the vessels inside it. I wouldn't advocate it. I have a huge experience in it. I don't do it anymore, and I would advocate it to someone. There are few surgeons who would do what we describe as radial stapled hemorrhoidectomy, which means they apply staplers at the base of the hemorrhoids, this is a procedure that is not yet looked into at the literature, and we don't know the outcome. The problem with it is that you leave huge amount of staples in the anal area, and you don't know how much of these staples will migrate onto the skin and the perianal area. So now that covers most of the hemorrhoidal, the hemorrhoidal issues. Okay. So Rasha is asking a question. Finally, we have a question. Let me check it. So how do post-operative pain levels differ between the multiple approaches of ligation, laser, staple? That's a very good question. And let me go back to. So that's a very good question. The highest level of pain is in the people where you perform excisional form of hemorrhoidectomy, because this is where you essentially excise some form of skin, and then they get a lot of pain. The second form of pain is in the. Does someone need to mute his mic? Okay. The second form of the second most painful or least painful is the hemorrhoidal ligation, because the hemorrhoidal ligation you will have to take deep bites, and these bites, some of them will involve the muscles, and then you do a mucopexy. So essentially you try to reduce these hemorrhoids backward, and you get a lot of edema, and this is where they get the feeling of a lump in the area for a few days. The least painful is the laser procedure. Laser procedure, if done perfectly, most of the patient can go home in the same day with a pain that is simply controlled by paracetamol. Any more questions on hemorrhoids? So Rawan Audi, can we use the HAL-RAR procedure with grade 3 and grade 4 hemorrhoids? If yes, what is the success rate? Another very good question, very well thought of. I would not consider hemorrhoidal artery ligation and rectoanal rectopexy on patient with grade 4. I think if you have someone who has circumferential grade 4, then you have to offer them what I describe as a staged hemorrhoidectomy. So you bring them in, you do one pedicle, you allow that to heal, you bring them 6 months later, and you do another pedicle. And usually that weight will tell you what will happen to the eventual hemorrhoids, because usually when you decrease the pressure by taking one hemorrhoidal plexus, the other will start to decrease in size. And that's why I don't do all of them or circumferential hemorrhoidectomy at the same time for large hemorrhoids, because you will end up with mainly bad anal stenosis. I would offer grade 3 hemorrhoids, definitely HAL-RAR, especially if their main symptom is bleeding, because that is the procedure of choice. It will control their bleeding completely, and it will reduce their hemorrhoids. Any other questions? So going again into another subject, and then what do I do with a patient that walks into my clinic with persistent perianal discharge? And here I'm alluding to the issue of an anal fistula. So you have to all be very careful when someone walks to your clinic with the symptoms of a perianal discharge, is especially when they give you the history of an abscess or the history of a lump that has burst, always come to think about it that, am I dealing with an anal fistula? Now, when you want to assess the patient, again, in the same position, you have to be very careful by looking at and assessing the anus very well and looking where is the external sphincter. Can I feel the sort of thick filamentous feeling of the fistula, and where is the internal opening. And hence, regarding this, you will know where the fistula is. And you have to start thinking, where is this fistula? Is it an anterior fistula or is it a posterior fistula? And in reality, it doesn't really make a difference if it's anterior or posterior. All what it is important to know is that the position of it might tell you where your internal opening could be. But that only applies for simple fistulas. It does not apply for complex fistula. The second question you need to ask is, how far is the external sphincter, the external opening from the anal canal? And the further away it is, the more complex it is. And hence, this is how you have to think about it and say, these are this patient has a complex fistula, this patient has a simple fistula. Now, a word of warning from someone who does a lot of fistula surgery: never be fooled by the position, because a lot of these fistulae are complex. Even if they look to you and to your bare eye, they are simple. I've burned my finger, and I'm sure everyone who does a lot of fistula surgery, they have burned their fingers. Usually, the position of the external sphincter will give you an idea, but it doesn't tell you all the truth. The truth is in an MRI. So all patients, take my advice, all patients who come to your clinic with an anal fistula, they should have an MRI. This is literally like, your Google map. You, instead of, going to ABC, Verdun, not knowing where it is and trying to ask 600 questions on the way, just, ask for an MRI and check your MRI, and the MRI will tell you, am I dealing with a simple fistula? Am I dealing with a branch fistula? And am I dealing with a complex fistula, whether it's transsphincteric, suprasphincteric, or a horseshoe fistula? These are the questions. For those who do not understand what do I mean by a complex fistula? A complex fistula means it's a fistula that is going across your sphincters. So it's not the simple intersphincteric or the submucosal fistula that you can simply treat by fistulotomy. The complex fistula are the fistula that goes across the sphincters and have multiple branches. These are the complex fistula. And fistulae are not easy to treat. A lot of people who treat fistula, they know very well that it's very hard to identify, to pick up which one is simple, which one is complex, simply without having an MRI. And a lot of the times you will burn your finger, you'll end up having either a high recurrence or you cause a significant injury by not looking at this fistulae. If someone of you is around AUBMC, I can invite them to come and see a patient tomorrow in clinic. A young girl treated in a nearby hospital with what's suggested as a simple fistula, and she has literally currently gone without her external sphincters and a decent portion of her levator on the left side. So this young girl is currently totally incontinent because whoever decided to do the surgery did not decide to have a proper evaluation preoperatively. I saw a patient yesterday who one of my patients who was treated in Abidjan in Africa with a decent surgeon who thought that he's treating her for a fissure when she really had a transsphincteric fistula. So an evaluation is very important before you treat this disease. Now, how do I treat? After obtaining an MRI, I think you treat the fistula with, if they are simple, you open them up, you lay them open, you do a fistulotomy. If they are complex, if you're not going to be a colorectal surgeon and you want to deal with them, then just apply a simple draining seton. There's nothing called cutting seton anymore. This is an obsolete procedure. It does not exist. It is a very painful procedure. It's causing a lot of pain. It causes a lot of muscle cutting. It does not exist, and it should not exist. So if you're going to deal with fistula in the future as future physicians, simple draining loose seton should be inserted, and then you send the patient to a colorectal surgeon or an anorectal surgeon who understands fistula better than you. If you can deal with them as a colorectal surgeon, then you insert a draining ceton, and then you identify the ideal procedure for that patient. And the three ideal procedures are either what we describe as a lift procedure, which we describe as this ligation of the intersphincteric fistula tract. You have to remember, when the fistula tract goes from going across the muscles, it goes through the intersphincteric space, and this is where you ligate it. So this is one form of treatment. The other form of treatment is a mucosal advancement flap, where you essentially create a flap on top of the internal opening and cover it with a decent, healthy, non-inflamed rectal mucosa. And the other one is FILAC, which is fistula in anal laser closure. And it's very similar to the laser concept of hemorrhoidal treatment. You close the fistula tract using laser power or laser energy. My advice for you would be is, you can treat fistulas as much as you want, as long as you understand that the complex one cannot be taken lightly, and you should not tackle them if you don't know how to tackle them, because you create more trouble for you and for the patient. You have to keep in mind that even in the best hands, a complex fistula recurrence rate stands at 30 to 40%. So even with the best hands and with the best methods, we all still have a 30 to 40% recurrent rate of complex fistulae. Now, I still have a few minutes to gain, and then I can leave the floor open for some questions if no one wants to butt in and ask me other questions now. Keep in mind the patient who come to you with very odd symptoms. So all of you are clued up physicians who, anytime, any person who comes to you with very odd history, so someone who you thought has a fissure has come to you and the fissure hasn't healed, constantly in pain, and you don't understand, the pain is really not compatible with that painful defecation that we spoke about, then ask the question, am I dealing with something else? Is this not a fissure? Is it something else that I have to look for? And then if the patient is in a lot of pain, do I have to do an examination under anesthesia? Am I dealing with an anal cancer? Am I dealing with a very low rectal cancer? So these are the issues that you have to think about. If someone comes to you and the patients are not typical of a fissure, but the patient pain is severe, am I dealing with a deep-seated abscess? And do I need an MRI? So always keep in mind these questions. Beware again of the patient who might have inflammatory bowel disease. So ask the questions about, non-GI manifestation of GI diseases, non-GI manifestation of IBD, of inflammatory bowel disease. Ask about uveitis, ask about skin lesions, ask about, sclerosing cholangitis, ask about abdominal pain, because it will give you the idea that I may not be dealing with a simple anal fissure patient. The same applies with hemorrhoids. If the patient comes into you with recurrent bleeding, you've banded these hemorrhoids, the patient comes in with rectal bleeding, you think you're dealing with a 35-year-old, this is hemorrhoids. It may not be hemorrhoids, then go and ask for an endoscopy. Make sure that they don't have a sigmoid cancer or an upper rectal cancer. So always remember that a lot of the anorectal pathology is straightforward, as I've highlighted. But some of the anorectal complaints might keep in their details pathologies that you may not expect. So always keep in mind that, am I dealing with something I have not seen before? Am I dealing with something else? Am I dealing with a pelvic, retrorectal tumor? All these issues you have to keep in mind before you indulge in doing a procedure on what you and I understand, or even the common population would understand as a simple procedure. Because when you have someone coming to you for an anal fissure and who needs a sphincterotomy, they have asked about it and they understand that this is a procedure that is very easy. Now, keep in mind there are always other related GI problems that can give you anorectal diseases. So, diverticular disease, perforated diverticular disease with a pelvic abscess presenting as a suprasphincteric fistula. Keep in mind obstructed defecation syndrome. A lot of ladies who present with obstructed defecation, which means their inability to defecate easily, they come to you with symptoms that a lot of people will interpret as hemorrhoids. And this is where you have to ask the patient about their defecation habits. Do they, and that's what I've highlighted before, ask the questions about, are you a chronic constipator? Is it really a constipation or is it really an obstructed defecation? Am I not being able to, is the patient not being able to produce while they're sitting on the toilets? These are all questions that you have to ask repeatedly, because sometimes you end up doing a hemorrhoid operation on a lady who had obstructed defecation, and all what she really needed maybe is a bit of biofeedback or some form of enemas repeatedly, and she did not need a hemorrhoidal procedure. So these are the issues that I want to highlight, and I would like to conclude that we in the Middle East, you see a lot of younger patients with very rare pathologies, squamous cell carcinomas, in a very low rectal carcinomas in 30-year-olds. I never saw them in the UK. So always be clued up and think about them, and don't send the patient with a simple procedure. I mean, last week I've had 2 patients who have been diagnosed to have rectal cancers because everyone thought that they have had hemorrhoids when they did not have, and they only diagnosed hemorrhoids when they've gone to the operating room to have a hemorrhoidectomy. And it tells a lot about you as a future surgeon if you do not diagnose the patient unless you've taken them to the operating room. Unless you know and you have told the patient, I'm taking you to the operating room because I don't know what you have. So I'll stop and I'll wait to answer some questions. So I have a question from Ra'id Tahat. What is the approach regarding the indication for colostomy in patients with abscesses? Do you mean patient with perianal abscesses? And I think this is a pure no-no unless the patient has significant perianal sepsis. So if you have someone who has big multiple abscesses in the ischiorectal area from either inflammatory bowel disease or perforated diverticular disease, then there is a role of a diversion. But to perform a diversion in order to treat perianal disease, to be extremely honest, that's that's a big call, and I would not. I have not diverted a patient for perianal disease. I have diverted patients who have had non-healing rectovaginal fistulas, or patients with a traumatic injury to the perianal muscles, but not for perianal abscesses. I hope I've answered your question. At the end of the day, you can easily have my email, and you can send me an email if you have further questions. I'm sure either Rasha or anyone has my email, and they can email me with questions about perianal diseases. Well, thank you very much. Again, I want to thank you for giving me this opportunity, and I think I'll see you in a couple of days to talk about inflammatory bowel disease.
Thank you so much, Doctor, for your time and
You're mostly welcome.
for giving us this lecture.
I've managed it in an hour, which is good.
Yes, thank you so much. And thanks everybody for tuning in. My name is Joelle Shami. I'm the Med 2 representative in Women in Surgery. And thank you so much once again. See you soon.
I'll see you Friday. Take care. Bye.
Bye.